Imagine two patients arriving in the emergency department with an oxygen saturation of 75%. Both appear equally hypoxic. Both are started on high-flow oxygen. Within minutes, the first patient's saturation rises to 98%, while the second patient's saturation barely changes. Why does oxygen work so well for one patient but not for the other? The answer lies in one of the most important concepts in respiratory physiology, ventilation-perfusion matching, commonly known as the VQ ratio. If you truly understand VQ relationships, you will understand the physiology behind COPD, pulmonary embolism, pneumonia, ARDS, atelectasis, and many other forms of respiratory failure. For gas exchange to occur efficiently, two things must happen simultaneously. First, fresh air must reach the alveoli. This is ventilation. Second, blood must reach the pulmonary capillaries surrounding these alveoli. This is perfusion, an alveolus that receives air but no blood cannot exchange gases. Likewise, an alveolus that receives blood but no air is equally useless. Gas exchange only occurs when ventilation and perfusion are matched. In a healthy adult, alveolar ventilation is approximately 4 liters per minute, while pulmonary blood flow is approximately 5 liters per minute. This produces an average ventilation-perfusion ratio of about 0.8. However, this average value can be misleading because the VQ ratio is not the same throughout the lung. Gravity affects both ventilation and perfusion, but it affects perfusion much more dramatically. At the apex of the lung, ventilation is relatively low compared with the lung base, but perfusion is even lower. As a result, the VQ ratio is high, often approaching 3. At the base of the lungs, both ventilation and perfusion increase, but perfusion increases much more. Consequently, the VQ ratio is lower, around 0.6. This regional difference explains why oxygen tension is naturally higher at the apex. This regional difference explains why oxygen tension is naturally higher at the apex of the lung and lower at the base, while carbon dioxide tension shows the opposite pattern. Now, let's discuss what happens when ventilation and perfusion become mismatched. One extreme occurs when ventilation is present but perfusion is absent. Imagine an alveolus receiving plenty of fresh air, but no blood is flowing through the surrounding capillaries. No oxygen can enter the bloodstream because there is no blood available to carry it away. Likewise, no carbon dioxide arrives to be exhaled. This situation is known as dead space ventilation. The classic example of dead space is pulmonary embolism. A clot blocks blood flow to the part of the lung. The alveoli remain ventilated, but perfusion is suddenly lost. Physiologically, these alveoli become useless. They receive air but cannot participate in gas exchange. In this situation, the VQ ratio approaches infinity because ventilation exists in the absence of perfusion. Now consider the opposite scenario. Blood flow reaches an alveolus normally, but ventilation is absent. Perhaps the alveolus is filled with fluid, collapsed, or obstructed. Blood passes through the pulmonary circulation without being oxygenated. This is known as a shunt. In a shunt, the VQ ratio approaches 0 because perfusion exists without ventilation. Common causes of shunt include pneumonia, pulmonary edema, ARDS, and atelectasis. These diseases fill or collapse alveoli, preventing ventilation while blood flow continues. The result is severe hypoxemia. One of the most clinically important differences between dead space and shunt is their response to oxygen therapy. Patients with VQ mismatch usually improve when supplemental oxygen is administered because some ventilation is still reaching affected areas. Increasing inspired oxygen increases the amount available for gas exchange. However, patients with true shunt physiology often respond poorly to oxygen therapy. The reason is simple. Blood is passing through non-ventilated alveoli. No matter how much oxygen you provide, it cannot reach blood flowing through alveoli that contain no air. This concept becomes critically important in ARDS. Many ARDS patients have severe shunt physiology. Despite receiving a very high concentration of oxygen, their oxygen saturation remains low because large portions of the lung are unavailable for ventilation. This is why strategies such as PEEP and alveolar regradement becomes essential. The goal is not merely to provide oxygen but to reopen collapsed alveoli so they can participate in gas exchange. From a board examination perspective, there are 5 major causes of hypoxemia. These include low inspired oxygen, hypoventilation, diffusion, ventilation-perfusion mismatch, and right to left shunting. Among these, VQ mismatch is the most common cause of hypoxemia encountered in clinical practice. When evaluating a patient with respiratory failure, always ask yourself a simple question. Is ventilation the problem, perfusion the problem, or both? Pulmonary embolism creates dead space, pneumonia creates shunt physiology. COPD typically produces VQ mismatch. ARDS often produces extensive shunting. Once you understand this framework, many respiratory diseases suddenly become much easier to understand.